So we're going to talk about a very simple concept today, which is the perfusion pressure of the eye equals the mean arterial pressure. And as you know, we spend more time in diastole, so it's 2/3 diastole and 1/3 systole, but it's minus the intraocular pressure. And so in neuro-op, we are dealing with conditions that result in ischemia that are either from a drop in mean arterial pressure or an acute rise in intraocular pressure, or both. And the conditions that come to us are non-arteritic anterior ischemic optic neuropathy. And as you know, this is to differentiate it from giant cell arteritis. So this is a non-arteritic ischemia of the optic nerve. And many people believe that NAION is caused by a nocturnal drop in MAP. So the nocturnal reduction in blood pressure is a natural process. And so when you're standing up, you have to auto-regulate and increase the blood pressure. But when you're going to sleep, we don't have to do that, so the blood pressure can go down. And so nocturnal hypotension is one of the presumptive causes, even though it's unproven, of garden variety non-arteritic anterior ischemic optic neuropathy. However, there are other conditions that can drop your blood pressure that you need to know about that could produce what looks like NAION. One of the most common is hemodialysis. So as you know, during the dialysis exchange process of hemodialysis, we have a number of things that are going wrong on the autoregulatory side in terms of sympathetic control, fluid exchange, and they are vasculopaths in general also. So intradialytic hypotension is one of the causes of NAION. So when we have a patient whose stem says, this is a 60-year-old white male, end-stage renal disease who is hemodialysis dependent and presents with acute unilateral loss of vision and a swollen nerve, even though garden variety NAION is on that list, we have to recognize that the drop in MAP from intradialytic hypotension during hemodialysis is a treatable risk factor to reduce the risk to the fellow eye. And so countermeasures could be done against this hemodialysis. In addition, surgery of any kind. So on the IOP side, that's intraocular surgeries that raise the intraocular pressure, including just general cataract extraction, but in particular, surgeries where they're injecting things into the eye. So both glaucoma surgeries and retina surgeries, injections of silicone oil, any type of retinal surgery can cause a rise in the intraocular pressure, independent of the mean arterial pressure, that can drop the perfusion pressure. So both intraocular surgeries and non-ocular surgeries. Non-ocular surgeries, however, usually work on the MAP side. And the most common non-ocular surgeries that cause NAION or posterior ischemic optic neuropathy, the disc is not swollen, both are ischemic optic neuropathies after non-ocular surgery, spine surgery, and cardiac surgery. And so in spine surgery, we have the additional risk factor of the face down position, and in the head down, face down position, that might impair the venous return and raise the intraocular pressure. There's going to be blood loss at the time of surgery, and they often have to be transfused. And the use of a Wilson device, which is used to push the spine up so they can get better access. So the face down, the Wilson device, the blood loss, and the hypotension in spine surgery can predispose to a drop in MAP, plus a decreased venous return and a potential elevated IOP could lead to non-garden variety NAION after spine surgery. Cardiac surgery is a lot easier to understand because they're working on the heart, but any surgery can result in postoperative cardiac arrest or atrial fibrillation, and these are mechanisms by which the perfusion pressure might drop from non-ocular types of surgery. In addition, we have other things that we have to worry about with MAP, which is iatrogenic. So if we give too much blood pressure medication, that can make the nocturnal hypotension worse, especially if the patient is being treated for white coat hypertension. They're actually not hypertensive, but their blood pressure goes up every time the doctor measures them. So inappropriate iatrogenic treatment of white coat hypertension could also drop the MAP. And then finally, there are conditions that transiently raise the intraocular pressure, and that can cause amaurosis fugax. And so when we have transient vision loss episodes, one of the mechanisms is hypotension, orthostatic hypotension, or failure of autoregulatory mechanisms, cardiac arrhythmias, presyncopal episodes, all are MAP sign. But if you have rapid rise in the intraocular pressure, like intermittent angle closure glaucoma, or if you have intermittent uveitis or Posner-Schlossman syndrome, you can get transient blackouts in your vision from the IOP side rather than the MAP side. So if you just know that the perfusion pressure equals the MIP minus the IOP, then you can try and figure out which side of the equation we're dealing with. Are we arterial pressure side dropping or IOP rising, either, neither, or both? And that is a super important concept that I hope you've learned today.